another hospital that we were at, but I'll just say our hospital. And he had subjective fevers, fatigue, also had a new onset of red eyes that were painful with movement, and also a 12-pound weight loss. And I'll stop there.
Oh gosh, no, I think Ravi, you're bringing up a fantastic case that I think illustrates a point that Reza made on Twitter recently, which is, there's the diagnostic journey that we assume that we're on, and then this patient gets diagnosed with TB, and then all of a sudden there's day 2 problems, and day 2 problems isn't meant to signify that it's happening on day 2, but meant to signify that it's happening as a new chapter after the assumed conclusion of the first one. And as a general principle, whenever you're like, oh, this patient's not following the natural history of the presumed diagnosis, you have to say, is it a complication of that, or were we wrong all the time? And by what I mean by complication of that, it's not just complication of TB, it's complication of TB and all the things that were thrown into the mix as a result of that diagnosis. So those could be the procedures required, like a CT and a pneumothorax. Those could be the diagnostic procedures and what they come with, like iodinated contrast and hyperthyroidism, or it could be the medication. So you have to remember that it's not just a complication of the diagnosis, it's a complication of the diagnostic journey, which are two very different things. And so here, I think that's the key question. The key question here is this TB rearing its ugly head in many ways, or were we wrong the whole time? And teasing that out is actually very, very tough. And often those two hypotheses are sought in parallel. And so I'll pass the mic to Charmaine to see what thoughts crossed her mind, but the lay of the land has to involve two parallel trains, which is this TB, and a complication of TB? Is this TB and a complication of the diagnostic journey associated with TB, or is this something completely independent?
Beautifully said, Archie. So maybe I can just think about the thread of like, oh, what if this is not TB, and what else? What we know is that the CD guided lung biopsy showed ill-defined granulomas, and we actually have a really good schema on granulomas on our website. And the things that I think about are like other infections and TBs, like anything from like other types of mycobacteria, Bartonella, fungal infections, like endemic mycoses, and then in non-infectious categories, the common ones to think about are autoimmune and cancer, especially like lymphoma. And autoimmune, we have our vasculitides, but there are other ones like Crohn's that can also do it as well. And then the rare is like immunodeficiency syndromes, and I think drugs that can also do it. And one of my favorite causes are fun to think about are like foreign bodies that can lead to granulomas, like anything from tattoo. And the fact that it can be metastatic, it just still blows my mind. But I think if you think about like, again, common things being common in someone who is presenting with fevers, weight loss, and kind of like multi-organ involvement, sounds like with dyspnea, with pleuritic chest pain, with some perhaps CNS involvement, then infection, autoimmune, and I think malignancies are the threads that we want to investigate more. And especially with the new onset red eyes, I think with that one, exam would be really, really helpful. Are we dealing with some like uveitis? Is this more like restriction in eye movements? So I think getting clarity on that can help us think about like whether we just like worry about the orbits and something local to the eye, or we have to like think about CNS. Can't wait to hear more, Ravi. This is off to what a start.
Okay, so past medical history other than the recently diagnosed TB, meds, just ripe therapy. Family history, none. Social history, works in construction. No other social behaviors, no health-related behaviors, no allergies. Getting to the physical exam. So bilateral scleral injection on auscultation of the lungs, pulmonary crackles. Just jumping back to head, neck, cervical lymphadenopathy. And then on skin, blanching, non-palpable purpura on his fingertips, as well as purpuric lesions on the right third and fifth toe. I'm just going to share my screen, see if I... I'm not sure if you can see the skin pictures. So these are some of the examples of the blanching non-palpable purpura on the fingertips, as well as the lesion on the right third and fifth toe. And I'll stop. Should I stop there?
Sure. Thanks so much, Robbie. Wow. Okay. So I'll just comment on the past medical history and then pass the mic to RG for some probably mind-blowing teaching, because he always does that. I think in terms of like medications and the right therapy, again, like as Robbie mentioned, one thread that we're invoking and we're thinking about is like, is there any complications of TB, any treatment of that? You know, with TB, if there's any CNS involvement and all of that, something to think about. You know, thinking about like any side effect from any drugs that we put patients on, less likely. But that's something that honestly to this date, to do things, I look up the medications and I run medications with our pharmacists on a regular basis. And my mind is always blown about all the things that I learn from them. And working in construction is something that just, in terms of exposures, that it jumps out to me as well. And then with that, I'll pass the mic for the physical exam to RG.
Yeah. You're like, here, I'm going to have the salad and you can have the fries, which by the way, is totally in line with Charmine as the champion salad eater. Charmine would always choose salad over fries, but oh my God, fries are way more delicious. And this exam is unbelievably fascinating. I'm going to try just to take it a step by step. So purpura means that there's red blood cells in the skin. And the question is it because there is bleeding in the skin, or is there because there's a vessel problem? And you can make a judgment about whether a purpura is because of a bleeding problem or is because of leaky blood vessels, or because of a coagulopathy or platelet issue by studying whether there's other evidence of bleeding elsewhere or evidence of ischemia. So if you just look at purpura, you're like, I know blood cells came out and into the skin. And the question is there because there's a vessel problem, or is it because there's a coagulopathy or thrombocytopenia? And when you look at that digit, you can see that that digit is necrotic and ischemic appearing. So when you see purpura in the context of signs of ischemia, the overwhelming odds are that there is a blood vessel wall problem. And so when you go into a blood vessel wall problem, often that immediately translates into an inflammatory blood vessel wall problem, namely vasculitis. So when you see this exam, your default hypothesis should be this is a vasculitis or another cause of inflammation within a blood vessel. And the causes of inflammation with the blood vessel are namely, the most common is endocarditis. So this exam, your reflex hypothesis should be, is there a vasculitis? But first I must rule out endocarditis. Now the words endocarditis are typically evocative of infections like staph, strep, rare gram-negative rods like the Haysick organisms, and not so evocative of the word granuloma. But that is not 100% true. In fact, all the causes of culture-negative endocarditis are all granulomatous infections. That's why you can't culture them. So Bartonella, Brucella, Coxiella are all granulomatous organisms. So when the word granuloma is percolating in the background for this patient and you're worried about endocarditis, you should think about the epidemiological exposure to granulomatous organisms, which are essentially another way of saying culture negative endocarditis. And the one that this patient would be at risk for by virtue of being alive and a human being and around cats and other things is Bartonella. Everyone is at risk for Bartonella simply by existing. But based on this specific epidemiological exposure from Nicaragua, you have to think about Brucella. But I think more importantly, if you take the words vasculitis and you sound really fancy, and instead of calling it vasculitis, you call it polyangiitis, which is essentially the term vasculitis. And then you were like, wait, I have a granuloma and I have a polyangiitis. Does this mean that this patient has granulomatosis with polyangiitis? And I think that's where the ocular exam is so telling. The endocarditis causes ocular complications. And those ocular complications are in the front of the eye and in the back of the eye. The front of the eye is some subconjunctival hemorrhage, which is pretty common in endocarditis, and then an ischemic disease to the retina. So you get all sorts of pathognomonic findings in the retina. But so the key question will be, is this injection in the eye, where is it? Is it conjunctival or is it scleral? And by Ravi telling us it's scleral, tells us that this patient has a 40 to 50% chance of having an autoimmune disease. Explain that. Because scleritis, unlike conjunctivitis, is often autoimmune. So this exam alone, expertly done, paints a very, very, very strong case for granuloma with polyangiitis. And why? It's because you're essentially saying this patient has purpura that is ischemic in nature, evocative of vasculitis, which is either autoimmune vasculitis or endocarditis. And endocarditis results in conjunctival and retinal disease and very rarely scleral disease. So the combination of a scleral involvement and vasculitic picture is very concerning for a vasculitis. And when there's a granuloma in the background, it's hard not to be worried about GPA. The truth is the story of GPA is actually a little bit complicated. You'll see that there's theories that GPA is triggered by infections like Staph aureus and potentially tuberculosis. So we'll have to pursue that hypothesis in parallel, but this is an outstanding exam, and the unique combination of sclera and vascular involvement is very concerning for an autoimmune disease. All right,
RG, that was brilliant.
The brilliance here is not putting the data together. The brilliance here is actually picking the data up. How many of us would have seen a red eye and been like, oh, it's conjunctivitis? How many of us would have seen purpura and said, you know what, it's not palpable, so it cannot be vasculitis? So honestly, the brilliance here is actually detecting the stuff because it's so easy to completely miss it. So kudos to the examiner. The examiner is the real pickup. But also, honestly, if I'm being honest, like we should be in these 30-minute plus Robbie rambling VMR, is I wouldn't be confident about these exam findings myself. Like I can never say, is this conjunctival or scleral? So I'd be leaning on experts
me too.
to make that determination.
Yeah, 100%. I would be lying to you if I could tell the difference between them. And RG, one question: TB can also cause scleritis, right? But like the purpuric thing with the purpuric rash, that's not in my English script for anything TB related. But I think scleritis can be seen with TB too, right?
As a non-expert, the concepts of uveitis and scleritis, and actually the most recent NGM case, I won't spoil it, involves keratitis. You'll see that the uvea, the sclera, and the cornea are very close to each other. So uveitis can spill over into scleritis, and scleritis can spill over to uveitis. They're right next to each other, tiny layers. Mm-hmm. So if you're confident that your patient has scleritis is typically autoimmune and typically a vascular autoimmune. So polyarteritis nodosa, rheumatoid arthritis, and GPA cause scleritis. In contrast, uveitis is typically autoimmune too, but is usually seronegative autoimmune diseases like spondyloarthropathies, IBD, Behçet's, so on and so forth. So in the world of uveitis and scleritis, autoimmunity predominates, but you're 100% right. The two notorious infections, hint, check out the New England Journal case, that that actually can cause both, you're 100% right, is TB and one other one. I won't say the other one because I don't want to run that case.
I'll text you just to make sure. I can't wait.
Yeah, but yeah, I think a TB can definitely do this. But you're right, the overlap with vasculitis at TB, I don't have a good one. So much for our 30 minutes ER rambling style clinical reasoning. We're just internal medicine nerds and we can't shake it. I'll be back to you.
All right, I'm going to speed it up. I'm going to share my screen for a second and show you the CAT. I'm going to jump to the CAT scan. The labs weren't particularly, didn't demonstrate much. I think the white count was 11, but the rest were pretty normal. The albumin was a little low. But the CTA, the X-ray also showed multifocal, so this consolidative pattern. But there were these bilateral pleural effusions and prominent mediastinal lymph nodes, and then these opacities, which you can sort of see here. So he definitely had a large number of things going on in the lung. He has some nice air bronchograms here. So that could also indicate possibly pneumonia going on. Maybe this part of his TB process as well. And I'll stop sharing there. So continuing on, would you like me to stop there? Do you have any thoughts before I disclose some additional labs?
Our birthday boss lady has
okay, yeah, happy birthday again. I'll be the one to shout it out. So, what was interesting with the team that was on the case, they initially thought with RIPE therapy, what if we're dealing with multi-drug resistant TB, although he's had culture negative so far. So possibly they did repeat the AFB again, it was negative. The multi-drug resistant TB PCR was also a negative. And then they did a search of the records outside and he's been tested for TB multiple times. So they're like, what if there's an alternative diagnosis? So the differential was broadened to include ANCA-associated vasculitis, just like Robbie had mentioned, and sarcoidosis was in the running, and possibly post-COVID-19 vasculopathy. So he did have, I forgot to mention at the beginning, he did have COVID a few months back. So additional workup notable for urinalysis with proteinuria, microscopic hematuria, and RBC CAS, C-ANCA titer 1 to 640, proteinase 3 IgG 835. So a diagnosis of GPA, as Robbie had mentioned, was made. He was followed up in the rheumatology clinic and had endorsed a marked improvement in his symptoms and health-related quality of life. So it was really interesting when Robbie mentioned, and I actually didn't really focus in on this episcleritis as part of this case. With GPA, it can affect the eye 50% of the time with patients and can provoke a nodular diffuse or necrotizing scleritis. And it can sometimes be the initial manifestation of GPA and typically presents with severe, deep, boring pain that can radiate to the temple and the jaw. And the pain peculiarly worsens at night, waking the patient up. And it can also manifest with eye redness and tenderness upon palpation. So the short story about the case, anchoring on TB from a person from Central America, we got to sort of avoid the stigmatization and think outside the box. And definitely GPA was the diagnosis that made a difference in this patient's life.
Robbie, you are just amazing. Thank you so much. Such an informative case. And I mean, that teaching point was just fire. I couldn't agree with more that, we should just, it's always like a great moment to check our own biases as well. And, one thing about like vasculitis, like autoimmune diseases, that it can't just, they're queen and kings of mimickers. And I think like this presentation, especially, I think, Robbie's teaching points about the scleritis was really informative. Just out of curiosity, most cases of like GPA that I've seen, I haven't actually seen pleural effusions associated with them. I don't know, Robbie, if you all have like any thoughts or comments about that.
I actually don't know. I honestly, it jumped out to me. I didn't expect to find any. So I don't know if Ravi knows, or I literally have nothing to add to that.
Yeah, actually, I don't have any information about that, but definitely now you've got me curious, and definitely will research this afterwards.
Me too. Me too. Yeah, that was like one thing that jumped out to me as well, and wondered if they like tapped it for any reasons. Either way, like I think the question is like, is it all GPA or is it GPA plus something else that is going on as well? But what a fantastic case, Robbie. Any reflections?
Yeah, I think I honestly think that Ravi's teaching us a really important lesson here, which is that one thing that I've been thinking about for life and for diagnosis in general is like what are we all inclined to do with information? And I think it's very hard to do, but you have to stick by the philosophy of letting information inform you, not bias you. And the difference between letting information informing you and biasing you is how locked your door is after you receive that information. So if you hear 45-year-old man from Nicaragua, you can't just take TB, put it in a room and lock it in there and not leave from that room. You certainly should put TB and put 30 pounds of weight associated with it, but be ready to lift that weight off should the cultures come back negative, because culture negative TB, while it exists, is rare. That's one piece of advice. My other piece of advice is actually actionable for you immediately, as opposed to sort of a lifelong philosophy that none of us will ever reach but strive for, which is whenever you hear the words granuloma, you want to have a checklist before you just say, okay, granuloma NOS. And that checklist is to ask, are there any malignant appearing cells next to that granulomatous process, such that would occur with lymphoma? And then the other one is there any vasculitis next to that granuloma? Because it wouldn't surprise me if upon review of this closely in the context of what happened, much easier to say after the vasculitis develops and the scleritis develops to look at that biopsy, would you have spotted vasculitis? And that's the ANCA-associated vasculitides are GPA and EGPA are granulomatous diseases, but surrounded by vasculitis. So for me, whenever I'm hearing or thinking about a case or even involving in a case that involves a granuloma, before I just label it as a granuloma period, I try to say, is this granuloma with evidence of vasculitis or is this granuloma with evidence of malignancy around it? And those help you avoid a lot of mistakes along the way. And it may not be something that you yourself can do as a pathologist, but something that you can prompt them to do if, for example, when they were telling you, oh, wait, there's a granuloma, you're like, wait, that patient's eyes were red. Is that a sign of vasculitis? So those are my two reflections on this absolutely outstanding case. Andrea, you want to take us home for the Charmine birthday VMR? I couldn't tell if you were doing them or if you got
Beautiful.
Sure. Feliz cumpleaños.
Andrea, right before the teaching service, just to close the loop, Thiago did very fast research, as he always does, and apparently GPA can pleural effusions can happen with GPA, that in less than 10% of the cases. So there you go. Thank you, Thiago. Appreciate you. Robbie, you're amazing. Robbie, always a pleasure. Andrea, take us away.
Feliz cumpleaños. So we started with a patient that we think, and we're thinking if it's natural history or it's a tuberculosis complication. And we said that we saw a granuloma. So Ravi talks about this checklist in which is malignant appearance cells next to it or is a vasculitis next to it. So this is a mental checklist that we should have. And when we think about granulomas, it's normal because of the board to think about sarcoidosis or tuberculosis, but there are other infections like mycosis, fungal, lymphoma, vasculitis, drugs, and immunodeficiency. This patient had a purpura that were red blood cells in the skin. This could be a vessel problem or a coagulopathy problem. And we also saw ischemia, that we see that there was a problem in the blood vessel wall. So we have to rule out, when you think about vasculitis, you also have to rule out endocarditis. In this case, it was a culture negative endocarditis. So normally those are caused by Bartonella or Brucella. Endocarditis can affect the eye. I didn't know this. So in the front, the front and the back of the eye. In the front, with some conjunctival hemorrhage, and in the back of the eye with ischemic disease of retina. And this and the union of this granuloma and this polyangiitis made us think about GPA. I also learned about this, that the eye exam, the uveitis can spill over scleritis, and scleritis can spill over the cornea. So scleritis tends to be secondary to autoimmune disease in the vessels, and uveitis tends to be caused by a seronegative autoimmune disease. Thank you very much.
Thank you all so much. Can't wait to see you tomorrow. Bye. Thanks again, everyone.